I am Dr. Dravid, Marketing Manager for Wolters Kluwer. I will be your moderator for today's event. Our objective for this webinar is that the participants should be able to understand how clinical decision support tools provide clinicians with knowledge ranging from clinical guidelines to patient-specific information, and how it can empower them to make smarter, quicker, and more informed decisions. Participants will have the opportunity to submit text questions to today's presenters by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation. We will collect this and address them during the Q&A session at the end of today's presentation. A recorded version of this webinar will also be available and it will be shared after the event. So today we have an excellent panel of speakers cutting from a digital health domain to a practicing physician. Now I would like to introduce today's expert speakers. So we have three speakers. So first is Dr. Oommen John. Dr. Oommen John is a physician researcher and a digital health expert working at the George Institute for Global Health. He is a conjoint lecturer at Faculty of Medicine, University of New South Wales, Sydney, and professor at Prasanna School of Public Health, Manipal Academy of Higher Education. He is an elected fellow of the International Academy of Health Science Informatics. His research interests are clinical decision support systems and their impact on improving outcomes. He has worked with World Health Organization and CRO on the measles aerosol vaccine development, and he serves on the Scientific Advisory Committee at FIND and Commonwealth Center for Digital Health. He is a member of the Access to COVID-19 Tools, Accelerated Diagnostics, and Digital Working Group. So then we have Dr. Sangeeta Sharma, Professor, Department of Neuropsychopharmacology, Institute of Human Behaviour and Allied Sciences, Delhi. She is the Honorary President for Delhi Society for Promotion of Rational Use of Drugs. She has been actively working in the forefront of promoting rational use of medicines with special focus on antimicrobial use, medication safety, and quality in healthcare. She has rich and diversified professional and managerial experience in healthcare. She has conducted more than 200 workshops to build capacity for doctors, nurses, and pharmacists. She has written several books. One of her pioneering work is a book called as Standard Treatment Guidelines, a manual for medical therapeutics. Also, she is the editor-in-chief for the South Asia edition of 5-Minute Consult Clinical Book. Then we have our next speaker, Dr. Jitesh KA, Medical Superintendent of District Hospitals in Alleppy as Assistant Director of Health Services. So graduate of Amrita School of Medicine and a graduate of MMST. He has also worked as State Consultant in Biomedical Engineering and State Nodal Officer to National Health Mission Kerala and a Technical Consultant to eHealth Kerala project. He has served as National External Assessor for NQAS conducted by NHSRC and as a Chief Coordinator of implementing Material Vigilance Program in Department and Hospitals of Kerala. His areas of interest are health economics, health technology assessment, quality assurance in public health facilities, biomedical engineering, and designing low-cost devices. For those of you just joining us, I welcome all of you once again. Now I hand over to Dr. Oommen John, so who would be presenting on clinical decision support. Sir, over to you. Neha, you may give the presenter rights to Dr. Oommen.
Thank you, Dr. David. It's a pleasure to be here. Thank you, everyone. Thank you, Wolters Kluwer, for having me. Can I share my slides? Okay. So, David, would you confirm that you're able to see the slides?
Yes, sir. It's perfectly visible. Please go on.
Yeah, thank you. So today's topic is on clinical decision support for general physician, but I would try to turn the pyramid and say that how can we actually use clinical decision support for strengthening primary care? And when we mean primary care is basically when a person comes into the first point of contact with the health system. And in most cases in our Indian context, because a large number of our people live in rural context as well as in urban context as well, they go to a family physician or a general practitioner first of all. And in many cases, at least pre-pandemic, they used to rush to tertiary care facilities. But I'm going to try and turn the pyramid down and see how a futuristic outlook to healthcare services delivery could be, and why clinical decision support in that context is primarily the key to achieving that. So I like to pay my respects in memory of two of our prominent leaders of this country, Arun Jaitley sir and Sushma Swaraj ji. So, in fact, Sushma Swaraj ji has been a Minister of Health as well. If you remember how both of them met their end, they, like in the case of Arunji, he was suddenly admitted into AIMS. He presented there with breathlessness and restlessness in August of 2019. He was 66 years old when this happened. And Sushma ji, again, around the same time in August, she was 67 years, again admitted to All India Institute of Medical Sciences with a massive heart attack. So quite often when we have people presenting like this, and we attribute that they eventually succumb to an event like a cardiac, a coronary event or a massive heart attack, or as in the case of Arunji, again, he also had a cardiac event. But again, both of them had went out publicly that they were being treated for kidney related problems and concurrent infections that they have developed, and they were being treated for the same. Similarly, Sushma ji also had attributed this to her underlying kidney disease. Does kidney disease present like this overnight? Perhaps not. So what we often see on the surface is just the tip of the iceberg, and that where exactly I would draw our attention today to. Okay, so emergency admissions, breathlessness and restlessness, or massive heart attacks is quite often keeping us busy, and this is what we tend to see and keeps us busy in our ICUs and in our emergencies. But what lies beneath the surface is our missed opportunities for detecting complication related to underlying diabetes or hypertension. And if we were to provide necessary nudges of improving better glycemic control or better hypertension control and provide a continuum of care, perhaps what we see above the surface and allowing us to see beneath the surface might actually improve clinical outcomes. So the question to ask ourselves here is, could early clinical decision support, or rather just decision support in the context of primary care setting, improve outcome in chronic conditions? As you know, India is quickly catching up on non-communicable diseases, and we have a very high burden of cardiovascular diseases, cancer, and all of this. But the question is, could early decision support in the context of primary care at the first point of contact with the physician help improve these? So let's look at this a little more in detail as we go into rural hinterlands. So we've been from the George Institute working in a district in Andhra Pradesh called Srikakulam, which is a coastal district, and this district is notorious for a large number of people presenting with kidney disease very early. There's people in the 30s and 40s dying of kidney failure. So we've been working with the government there to understand what is going on. And when we did a survey, a systematic assessment of a population-based assessment, we found that about 42 out of 100 people that we had surveyed had high blood pressure. About 13 in 100 had diabetes, and 14 in 100 had in some other family member affected with kidney disease. Okay, now these are people living in rural Andhra Pradesh, and the nearest hospital would be about 100 kilometers away. They are with many of their presenting symptoms of high blood pressure, of diabetes, and of perhaps even kidney disease. they would be going to their primary care physician, general practitioners, or even registered medical practitioners, but might not necessarily get picked up for want of good decision support in terms of what diagnostics to look for or what diagnostics to use. How do you interpret those diagnostics? How do you infer what is going on? How do you actually intervene early so that you can prevent complications such as kidney disease or cardiovascular events much lower down the range? Okay. This takes us to an interesting concept actually from economics, which actually asks us what really influences health decisions. Okay, so we have a person with diabetes or with hypertension, and like I mentioned to you, quite often when they meet the health system is when they have a emergency. So somebody who is having diabetic ketoacidosis comes in coma, and that is the first time they get picked up that they have diabetes. Or when somebody is having heart failure because of their long-standing hypertension, they come and get into a ICU facility, a tertiary care facility. That is the first time they're actually being picked up that they are actually having long-standing hypertension. Okay, so if diabetes is such an important one, how can we enable our primary care physicians, our general practitioners to improve their decision making right at the beginning? Okay, so can we use triggers to influence decisions, such as one important parameter that one looks for is hemoglobin, glycosylated hemoglobin. And we know that anybody whose glycemic control is less than 6.5 tends to have a good profile, and they do not develop the kind of complications those with more values of or poor glycemic control have. Similar is the case for hypertension. Now, if you were to go into the principles of economics, I wouldn't go too much into it. Basically, if we were to say that there is a reward of maintaining one's hemoglobin, glycosylated hemoglobin at 6.5, which is a future event. Okay, so I don't want to have a cardiovascular event, a heart attack 10 years down the line. If I don't want to do that, I really need to keep my HbA1c below 6.5. Okay, now can we use tools both for the patients, more so for the primary care physicians, to enable doing this? So in summary, what we are talking about clinical decision support is we need to have tools that enable our general physicians, primary care physicians, or the first point of contact physicians. So we call them as primary healthcare or the first point of contact. And can we use clinical decision support tools at the point of their care delivery? Okay. So 4 questions to ask in this context is, whose decisions are being supported? Okay, so we know in the context of our conversation today, we are interested in supporting the decisions of primary healthcare providers, which is our general practitioners, or as we would call it, a PHC doctor, or in an urban context, it would be a family physician or somebody at the corner shop or corner clinic or mohalla clinic in Delhi context. Okay, what kind of information is being presented? Okay, this is very key. And more importantly is, when is this information being presented and how is it being presented? Okay, it is very, very important. When we talk about clinical decision support, it is just not just a whole bouquet of things that is just thrown at the physician, but how we contextualize the decision support in understanding what decisions are being supported, whose decisions are being supported, what kind of information is being presented, more so when is it presented. So ideal place where we present decision support is when that decision is being made. There are studies that say that almost in a daily clinical practice, about 40% of the clinical encounters end up with questions. Okay, if at that point when there is a question, okay, so let's assume that there is a person who's had COVID coming back to us after 3 months with some sort of vague symptoms. Okay, he's got hair fall, he or she has got ulcers in the mouth, and let's say urinary tract infection. Okay, so when that person come to us at that point, we have a number of questions. Okay, how do I investigate this further? Okay, what am I dealing with? Okay, and what is the course of management I am going to take? Okay, so if we present at that point of decision making relevant decision support interventions, then we will be able to actually help support that decision making. Okay, I'm sure Dr. Sangeeta is going to be speaking a lot on rational drug use. So I will take an example from a published study about why it is important to have decision support in terms of appropriateness of laboratory tests, particularly in ordering what kind of tests, okay, without necessarily increasing diagnostic error. Okay, this is a cluster randomized trial that was conducted, and so we know in regular practice, all of us who are in practice know that when we have a patient who has got particularly vague symptoms, we just order a battery of investigation, and then when we order a large, when we actually throw out a big net, we get some fish. Okay, we will have some values which are out of range, some findings which are unexplainable, and then we have to go and chase these things. Okay, quite often we end up with incidentalomas, which is basically something which has been there incidental, but then we go chasing them and then end up wasting a lot of resources and time. Okay, so decision support tool in actually deciding what kind of laboratory test to do in primary care context without increasing diagnostic error is a key aspect. I would encourage all of us on this call to go through the study, and it's really wonderful to see how this cluster randomized trial has demonstrated that if you use a proper approach of decision support for choosing the right kind of laboratory test, you can actually pinpoint what kind of test to use, what kind of result to expect, and how that can actually limit both diagnostic errors as well as out-of-pocket expenditure in context where people pay out of pocket. So I will stop here because my time is over, and I would be available at the end of all of our conversations to take on any questions. Thank you, Dravid. Over to you.
Thank you, sir. Thank you for giving us an overview of clinical decision support, especially giving us with examples. So especially with an Indian context, so that the participants would be able to understand why, what is the need and what is the paradigm shift. So maybe 2 or 3 years back, we have not maybe inculcated the sort of clinical decision supports in our daily practice. But yeah, it has been there as a discussion point or a moot point for long. But this pandemic, I can for sure say that it is hastening the process of inculcating or integrating into their daily practice. Thanks for giving that overview. And right now, I will invite Dr. Sangeeta Sharma to give her topic. Thank you, sir. Ma'am, over to you.
Thank you, Dr. Dravid, for giving me this opportunity to share my experiences on evidence-based resources and the evidence-based practice, how they improve the practice in making decisions more consistent. Can I share? Can you see my screen?
Yes, ma'am. It's visible, so you can put it on slideshow.
Yeah.
Perfect, ma'am. Please go on.
Okay. Good afternoon, everyone. I'm going to talk about evidence-based resources, how this helps in making confident and consistent decisions in your practice. Before I go into that, let's see, what is the problem, related to this. Medicines are the cornerstone of management of many diseases. They save lives when used appropriately. But what is the paradox these days is that we have excess on one hand, there are thousands and lakhs of medicines which are available in the market. More of them are, just the brand name of one molecule. There are problems with the naming, packaging, nomenclature of these medicines, over-the-counter availability on one hand, but at the same time, we are also struggling with the access to many of these medicines to those who are actually in need of these medicines. And we all agree that the goal of the healthcare system is to provide universal access to reasonable healthcare. So now let's see, what are the problems when which we come across when providing reasonable healthcare to people, those who are in need. So let's see the current prescribing practices. There is a huge variation in clinical practice. Even if you have to, if you look at the treatment for even common cold, upper respiratory tract infection, or fever, and even COVID, these days, despite having standard guidelines on this, we find that there is a huge variation in clinical practice. And, I have been interacting with lots of experts and the physicians while updating my book on standard treatment guideline. And I find that there is a mix-up or a conundrum between what is past practice and what is evidence-based practice. More often, I find people rely on their past practice and they say that we have been using this for many years. So how can it be wrong? So, but evidence may not support this kind of past practice. And also there has been an increased demand for care because of the access and availability of the treatment options, and it has increased the healthcare costs. So many of us are making out-of-pocket expenditures, though this is a regressive system, financing system, but most of us are depending on the out-of-pocket expenditures. There are concerns about rising litigation rates, number of medical negligence cases against the doctors, hospitals, and because of various patient safety issues and quality concerns. So these are the problems these days. So what do you need to avoid these problems? What do you need for optimal use of medicines and to be able to prescribe rationally and cost effectively? A physician requires an up-to-date, objective, unbiased drug information which is contextual. What is first line of treatment in developed countries in US or UK may not be the first line treatment here in South Asia or in Indian settings, or it could be the other way around also. Here in UK or US, all of you may know, they may have to wait for an ultrasound or an MRI for an investigation, but here you may get it as a just next door facility here. So you need to have a contextual information made available to the physician, and which is readily accessible. Readily accessible means when you are prescribing, when you are writing a prescription for your patient, it should be available at that time. And we know, even if you are able to fetch up-to-date, unbiased information, there is a lag between evidence and the practice. We may have an evidence. We had this evidence for hand hygiene for several years. We had been advocating that this reduces the number of infections, but we were not, practicing this in our day-to-day practice. But COVID, thanks to, it is a blessing in disguise that the COVID made us follow hand hygiene. So similarly, there are many other areas where there is an evidence, but the same is not followed in practice. So there is a gap between this. So how do you close this gap? How do you go from evidence to action here? Because on one hand, hand, there are fourfold problems here. There is a practice variation. There are patient safety issues because of the misuse of the medicines or not choosing the right treatment plan for the patient, or knowledge translation from research to practice and quality improvement. So evidence-based resources are considered as one of the tools to reduce this gap between the current practice and the best practice. Now, there is an increasing trend for using evidence-based medicine for making decisions, where the clinical science helps the physician in making the decision about the treatment plan for a patient. Of course, this is integrated with the clinical expertise and patient values. Then only it is taken into the practice. That's how it becomes evidence-based practice. Now let us know from where do you get this evidence? What are the resources for learning about this evidence-based practice? This includes clinical point of care tools, practice guidelines, systematic reviews, literature databases, and background sources. So all of these are available. Now we need to know, how do we use this? How do we select which one is good for us? Now there is a research is being generated at an exponential rate. Nearly 1,000 or more than that articles are published every day. So so much is available, but is that being generally readily made available to clinicians? And even if it is made available, is it applied frequently? And most often, if you look at the resources, and in your own practice, if you look at the resources which you use in your practices, textbooks and the advice given from the peers or colleagues. But the problem with sometimes with the textbooks is that they are frequently out of date. They are brought 2-3 years after 2-3 years. So in between there may be an advance which may not be reflected in the textbook. And there is a fear that when you take advice from the colleagues, it may be inaccurate, because then again there is a mix-up between past practice and the evidence-based practice. I'm shown here, this is an ongoing study here where I was trying to look at the important sources of information, and you find that there is a mix of it. Most of us depend on the formal education textbook, peer discussion with peers, colleagues, residency training, personal experience. Although some of the participants were also using clinical guidelines and formal peer review research article, but other sources are also frequently coming up here. And even with when you are using these peer reviewed research articles or systematic reviews, they are infrequently used in clinical based practice. Now, major problem with the research articles is that there may be conflicting reports. When I was doing this, writing this chapter, I came across, calcium on, whether they are cardioprotective or what are the harms of the calcium. And I found conflicting reports. One report saying calcium supplements are cardiac safe. And on the other hand, I also found reports where they say this is a heart attack is a deadly side effect of calcium. So another study said calcium supplements are linked to heart attack. So in fact, they come up with the title of the this review, that are these calcium supplements and to resolve this issue, calcium supplements and heart attacks. More the data we are having, and more it is raising more and more questions. So how do we deal about this conflicting reports which are appearing in the literature every day? So other barriers are, lack of time, skills for critical appraisal. You need to review these reports very carefully to be able to use it in practice. So, and also, as I said, there is a significant lag between the publication of a clinical advance and its adoption into the clinical practice. And moreover, even if you have access to these systematic reviews, the problem with the systematic reviews is contents are not sufficient to meet the needs of the clinician, because they are focusing more on the validity of the evidence rather than the applicability of the evidence in the general day-to-day practice. So when you start looking at data, you come across different types of publications, literature reviews, systematic reviews, meta-analysis. Ideally, the systematic reviews and meta-analysis provide the highest level of evidence. That means you can trust these the findings of the systematic review and meta-analysis and use this in clinical practice. And many of the experts suggest that when you are looking for an answer to a clinical question, you first look at the systematic review. But the major barrier to systematic review use in practice is that not every topic will have a systematic review or a meta-analysis done. So there may be many clinical situations where you don't find this kind of literature available for you. And also, even if it is available for a particular topic, you may find that the interventions details are not given, or they don't talk about the risks of adverse events and the context in which these interventions may or may not work. So there is a good and bad evidence available, but you need to do some critical appraisal, if especially if there is both kind of evidence is available. Recent example I would give, ivermectin, whether you should use as a mass medicine for COVID treatment or not. I was going through this, I found both types of literature available. So it's very difficult for the general physician to make a decision whether ivermectin should be used in practice for mass treatment of COVID or not. Similarly, evidence-based information resources are not created equal. There is a grading criteria which takes into account the quality of the evidence, the strength of the evidence. When you say quality of the evidence, you look at the background literature, whether it is a observation study or a randomized control study, or you look at whether it is a meta-analysis or a systematic review. And when you are looking at these studies, you look at does this instill confidence in you? Can you adopt this findings? Whether the evidence is strong enough that you make it as a policy matter, or that you treat all your patients with that intervention, or is this the strength of the evidence is weak? Where you have to select patients where you can apply. So there are a lot of concerns about using these resources in general practice. So what do you do? How do you manage? I have highlighted all the problems available of the evidence available. So that means you need better knowledge tools and products. When you were talking about these tools and products, that there are three cardinal features of evidence-based communication. These are called 3 R's. These are reliability, relevance, and readability. You're looking at the evidence is considered reliable if it can shown to be highly valid, and methods used to generate this evidence are explicit, rigorous, and at least the best available. And relevance, you call it when you distill this and you index this from medical literature, and relevance would be more if it is specific to the distinct need of a primary care physician, tertiary care, or a super specialty, cardiologist or a neurologist, or a certain group of clinician. More the relevance, more it fits into the distinct needs of the particular group of clinician, better is the relevance and better is the adoption of that evidence into practice. And moreover, all these formats should be user friendly, should provide sufficient details. You have to have a balance here between brevity and the detail, and which allows implementation in the clinic or a bedside. Now, we all know that there are inherent problems with each of these three R's, but when you come across challenges with these, balancing these three R's, reliability should trump over relevance, and both reliability and relevance should trump over readability. So reliability of the evidence is quite important. Now, coming to this, ideally, resources become more reliable, relevant, and readable as you go up the pyramid here. So this is called 5S pyramid. Systems or the policies, when they get into that, they become more reliable and relevant. But at the bottom of this pyramid are the studies, original articles. I told you about the literature which is already available. At the next level is that synthesis. When you have a specific clinical question, you have a systematic review to answer those specific questions, and then next, this is followed by synopsis. Here this is a these synopsis, they do critical analysis of the evidence available looking at a particular question. So many example, these clubs, evidence-based journal abstracts or evidence-based medicines, they come at this level. And then comes the summaries. This is a comprehensive this gives you the comprehensive overview of the evidence related to a specific question, and there are various online resources these days available. Some of these are listed here. And finally, when it gets into the decision making or the policy, it gets into the system. So ideally, you should be using this systems, but we find that such a electronic health records are not so available. Then you can use these summaries for making decisions for your patients. So when you follow these, clinical decision support systems, you are in fact standardizing care, and it serves as a basis for assessing clinical practice, reduces disparity in care, raises the quality level, inspires collection of data to improve better outcomes, provides education for healthcare professionals, and reduces the risk to healthcare providers and medical insurance because of the efficient use of healthcare resources, and achieves the best balance between the cost and the treatment, looking at the effectiveness, specificity, sensitivity, etc. So when you use these clinical decision support systems, these evidence-based resources, healthcare providers, they get the expert consensus on this. They need not go into the details, methodology, statistics part. So they get an expert consensus whether this evidence is good or bad, whether they should be using it or not. And you get more time to concentrate on diagnosis, treatment part, what to choose for which patient. And also it helps to practitioners, especially those working at the lower skill level. It helps them in educating, what is the best treatment available, and it adds value to the health system by standardizing evidence-based protocols, bridges the gap between the science and practice, uses near real-time data to make care decisions, improves quality, reduces the use of unnecessary, ineffective, or harmful interventions. Besides rational use, there are many medicines which we find are being used, which are not necessary. There is no evidence to support their use. During this COVID time, you must be, recollecting. People ate vitamin C like food, zinc, so much so, heavy dose of zinc was given that, mucormycosis, one of the cause of this overload with the zinc for mucormycosis was this. So if you use evidence-based, it improves transparency, accountability, and value. So you need to balance this cost and the value you are getting, and certainly it helps in improving the patient outcomes. So when you are practicing these evidence-based practice, it has to be patient-centered. So there are 5 A's here: assess, ask, acquire, appraise, and apply. When you follow through these 5 steps, it gives more evidence. Your practice is more evidence based. When you assess the patient based on their examination, need, and morbidity, the treatment, prognosis, harm that the patient may have on the patient, it will help you in wisely choosing the treatment plans which are best for your patient. And EBM resources here act as a ready-made evidence for you. Most of the time, evidence is available for various questions, but there are certain situations where this kind of evidence may not be so readily available. But when it is readily available, it can be used. You can trust those, and then you appraise this evidence that whether you can depend on this methodology, intervention, or a setting. Based on that, then you review your performance, review the performance of a new strategy or a treatment plan and outcome, and then you revise the background question, and this cycle goes on. So in evidence-based practice, somebody has already done, when you use these resources, somebody has already done this exercise for you. And 5MC clinical consult is also one of that level of synopsis and summaries, where evidence-based summaries are provided and frequently updated, and they are available for a wide range of clinical topics, and they are reader-friendly. They provide you the algorithms here, clinical information, the diagnosis part, the risk factors, prognosis, monitoring part, patient education part, besides other details about which you need to know while treating your patients are provided here in this evidence-based resource. I think I'd like to end here. Evidence-based practice, we knew these are 3 essential components that you need to use best evidence. Clinical expertise is required. You should know when this evidence would be applicable or suitable for your patient and when it is not. That is an equally important question for us to know when this evidence does not apply, or when should you go outside of this evidence or individualized therapy or based treatment on the patient's characteristics, needs, values, or preferences. And all these things should be taken into context, the environmental context and the organizational context. It depends on the organization also whether they are supportive of this evidence-based practice or not. I think that's all I have to say. Thank you.
Thank you, ma'am. Thank you for giving us this overview of how evidence-based resources can help in bridging the gap, especially in terms of care variability. And actually, you touched one point where current practice is best practice. So when you said that, it sort of brought me some memories of my college days. So when one of my professors during my practice days, so he said it is not about current practices versus best practice. It is about best practice versus best available practice. So of course we have come a long way now. Yes, and thanks for giving us an overview of levels of evidence, how practitioners should be able to use that when they make a decision. So our next speaker is Dr. Jitesh. So that's a very interesting talk because we have one of our clinical decision support tool called as a 5-minute consult, designed especially for general physicians. So he has used it, and then he's going to share how he has used it and how his team is using it, and general overview of his care and institution. Over to you, Dr. Jitesh. Welcome you once again.
Thank you, Dr. David. It's my pleasure to talk in a webinar like this. I'll be talking some relevant points regarding the 5-minute consult that application. Its relevance in a public health institution like mine. So I'll be talking to you briefly about the scenario in which I am working right now. That's a public health institution, and how this 5-minute consult, what exactly is 5-minute consult according to my perception, and then where all it is relevant, and when it is relevant, and a certain feedbacks regarding the 5-minute that application. So right now I am working as a medical superintendent at District Hospital Mavelikara, which is in Alleppy district of Kerala. So we have it's a secondary care institution. It's not a primary care institution where Dr.Oommen was really pointing out the primary care scenario in using 5-minute this evidence-based practice there. I'm working in a secondary care institution in which there are accident and emergency department, outpatient departments, inpatient departments, and specialty care points, especially dialysis center, district cancer care center, and now we are starting with the district daycare center for hemoglobinopathies. So certain like a wide variety of departments are there in my hospital, and to talk about the patient load in our institution, it's around per OP, that is like per doctor, you I mean on an average 100 to 150 OP outpatients are there, and around 1,800 odd OP per day. And accident and emergency attendance is around 250 to 300. If you calculate it, like time given for a patient varies between 2 to 5 minutes. If you consider it is, I mean, it's just if you consider everyone is given equal time, but because of our the practice strategy, effectively we are effectively managing our OP time, and we are giving up to 15 to 20 minutes per case, which requires that much attention. And we are those patients who are coming for follow-up, like that we are I mean, reducing their time, and like that we are effectively managing using some strategies. And talking about those strategies, one of the, I mean, in the outpatient department and accident and emergency, we are effectively using our the triaging facilities, in which we can reduce that patient waiting time, and for those critically ill patients, and we are like categorizing such kind of patients, and giving more time to those which require more clinical examination time, and use techniques called I have put it as to buy some time. Certain cases, when we are seeing, we see that okay, there is something we have to look more into that. So as a clinician, I would like I will send this patient for us like whatever relevant examination or investigations, and then I'll get some time in which I have to actually think about his diagnosis and management. And after getting the baseline investigation, I have to dig more into that to arrive at that diagnosis and managing that patient. So there is it's actually a terminology which is kind of used widely in the general practice side, that is to buy some time for invest for some decision to arrive. So that is through the detailed examination and investigations we are managing that. And definitely have to admit the patient and investigate more, or we'll keep if it is not like we have a dilemma whether the patient needs to be admitted or not, but we cannot send them back. Then we'll go for observation. So this is an overview of our scenario in our institution. And coming to the clinical decision support systems, that is why we require a clinical decision support system. That is actually exactly we have learned from Dr. Sangeeta's. There are a lot of evidences available in our web or internet, but we don't know as a clinician what to trust. We don't know. Like in the textbook, which may be 2 to 3 years ahead. We will be actually practicing 2 to 3 years ahead of the time of publication of that textbook. But we are in a confusion to what to arrive at, what is to be done next, like that. So for that we require some kind of help. What is the best available practice at this moment? As Dr. Dept told, like it is the best available practice which has to be sort of, and it is exactly at that point this evidence-based clinical practice is put into use using this clinical decision support system. So people whenever we hear clinical decision support system, my colleagues and my other fellow doctors, those who are not that well versed with clinical decision support system, they usually ask whether it is a replacement of our doctor's thought process or decision-making process. Not actually exact replacement of doctor's decision-making process, but it will definitely help us arriving at right decisions, right to strategize our patient management, or to make the next step ahead, like what is the best investigation method out, like that. So this is actually a kind of an aid in the diagnosis, investigation, and planning, the management part of the of any patient practice. And we have to actually also not just arriving into a diagnosis, we have to sometimes rule out other possible conditions also. And at the end of the day, we will get a better outcome of using the clinical decision support system in our concurrent practice. So to tell about 5-minute consult, I have used this 5-minute consult for a few days, and I have this is my personal opinion about it has got a it has got a global search in the in itself. So whatever condition you want to know, or situation you want to know, just type it in, and we are going to get a full list of whatever available content in that application. And I have found it very helpful in finding some conditions in my practice. And we have there are some diagnostic and management algorithms incorporated also. So it's I think it is the basic concept is taken from the 5-minute consult book that is being published, and we are getting a lot of diagnostic algorithms and management algorithms. So we have got we'll get some idea about what move to be made next, like that. And it is more, I have found that it is more relevant to our Southeast Asian region, or particularly to our India. That's what I have seen. Lab investigations, there are details of various lab investigations available. And there are some patient handout, patient exercises pages that also, which are also there. So altogether, I have used this 5-minute consult for a few days, and what I have found is that when and where it is actually relevant. In our day-to-day clinical practice as a general physician or a physician in a hospital in a secondary care institution, we like after making a working diagnosis, we may have to use this kind of decision support system not in every condition, but maybe in a condition in which we require up-to-date information, like the latest guideline, whether to use this drug or a combination of a drug or like that, or whether to do some more investigation, whether to like that. So certain conditions, certain questions we have to answer, like what could it be, like the diagnosis, whether if we have a dilemma in diagnosing, we can use it, and we to get an answer about what is the next best step, or to like could that be, or if it is in a disease, what type it should be, or what class or category or stage of the disease it is. For those conditions, we can use this 5-minute consult or such diagnostic tools. And sorry, in the diagnostic process, I have I think in every step we can even use this this kind of clinical decision support system to arrive at a working diagnosis, to confirm a diagnosis, eliminating the alternate diagnosis, and even in the managing the condition, as Dr. Sangeeta was telling, like while managing the disease, whether we are using the right medicines, whether to change to another set of or regimen of medicines, like that. And to academically also to have an in-depth knowledge about the disease or condition, and also we can even use for patient education also, we can use such kind of application. And the next step, I'm going to have some feedback. I have used a 5-minute consult, and also previously up to date I have used for a couple of months. So I found a 5-minute consult to be more relevant to our general practice kind of thing. Whereas this up to date, I found it. I thought I found that it is more relevant for a tertiary care institution or a teaching institution, where you can have a better, like a wide variety of things, wider things. And this is more precise. And coming to the user interface, I have I'll give 4 out of 5. Like it is user friendly, and we are getting it in 2-3 clicks itself. And content wise, I found it very okay. Like we, as you always know, that this content has to be like every day it has to be updated like that. So content wise, I have I thought I am whatever I have seen is that it is relevant to our scenario, and it is more precise, not too much like too much content is not required in a setting like a secondary care or primary care institution, where you don't get that much time. That's the thing. And whatever I have seen as patient advisories, like patient this one information handouts, and also the exercise, it is also very good, and that is actually relevant also. And about the investigations, I have found lab investigations, extensive list of lab investigations arranged properly there. For us, it is like to get a special test or something. You just need to scroll down the details about that investigation, and also about some clinical procedures. It is given properly how to do each procedures also it is there. So overall, these are all good points that I have seen in 5-minute consult, and some things in which scopes to improve also have been found. First thing, see, in 5-minute consult, everything is actually arranged alphabetically, but our doctor's thought process, our thought process is not that much in a orderly arrangement as alphabetical order. We think system wise, and like our whenever we have a patient, we'll think whether it is a cardiovascular issue or a gastro GI issue or some. We used to think we are like taught to think about system wise, and that kind of an arrangement is not there in this 5-minute consult. I will suggest or request you to look into that and to add an additional layer of content classification based on the system wise this one, so that we can look into that. And also while investigation also, we used to go like a hematological investigation, biochemical investigations, immunological investigations, like that. So such kind of arrangement can actually aid in more like a user-friendly kind or doctor-friendly kind of this one. And also this one negative point that I thought. Suppose I'm not sure about a diagnosis. I don't remember the name of the diagnosis, but I know that it is in this system coming under the another, like for example, if I am having a patient of peripheral arthritis, inflammation of arteries. So I have to look for Kawasaki disease, but I don't remember that Kawasaki the name. So we'll get the name called as Kawasaki. Whereas if it is like cardiovascular system, peripheral vascular system, and autoimmune or like that, if it will be more to piece from the given list of items. So adding an additional layer of content classification will always help, I guess. And in the lab investigation, the imaging investigations are not done, especially like some conditions have like classic X-ray features or classic ultrasound features. So while after getting a X-ray, we have to actually look for that specific point, and adding such diagrams in under the investigation, like imaging investigations, that will be better, I guess. And to ask, there is no limit to ask. We can because patient handouts are we can, if we are in India, it is like we each place we have our own vernacular languages, and having a patient handout in our vernacular will be more easy for a doctor to use it. And additional like integration with the existing e-health, electronic health record will be more useful. These are all my view, and over to you, Dr.
Thank you, Dr. Jitesh, for giving us an wonderful overview of 5-minute consult, which is available both in website and also in app form. So people can use it, and then we have a link if they are willing to look for a trial, so they can fill the form, and then we would be happy to initiate a free trial access. So now we will go back to the questions. So we have a few questions from the audience as well. So let me initiate. So first question is to Dr. Oommen. How do you view India's digital health policy advocating use of digital tools for improving the efficiency and outcome of the healthcare system, and what impact it can have at the grassroots level?
So, as we know, there have been efforts by Ministry of Health in embedding clinical decision tools into the applications that the frontline healthcare workers use. The NCD application is one such example where the frontline healthcare workers use that for screening for common non-communicable diseases, and that has a decision support system that has been kind of based on primarily standard treatment guidelines that have been developed by experts in India, led by All India Institute of Medical Sciences, as well as the ICMR guidelines. ICMR standard treatment guidelines have been incorporated into that. Generally speaking, the way the health and wellness centers are designed, are being rolled out, there will be a digital core to it, and that will have a strong component of clinical decision support tools as part of, because what is the care delivery envisaged is that a mid-level provider will be the first point of contact, and he or she will be able to provide much of the primary care that is necessary, and therefore task shifting, as they call it, for clinical decisions is being planned as part of the program. So yes, in a nutshell, yes, digital tools are being used, and the larger plan of the rollout of the health and wellness centers does take into consideration this at scale. Yeah. Over.
Yeah. Thank you, sir. And next question is for Dr. Sangeeta. It's a twofold question, so let me put that in a single question, and then you can answer both. So the question is, how well accepted and understood are these evidence-based resources? And moving forward, how are there any practical ways so one can integrate these elements of evidence-based resources into practice?
Yeah, very good question. I think that was the basis of that's what I was trying to address this in my session. That it's difficult to understand. Evidence. There are different categories of evidence grading: high quality, low quality, then strong evidence, weak. So it is very difficult to understand, and there is no one size which fits all provides all the solutions. So that is why these clinical guidelines are needed, because in general people don't have the skills to perform this critical appraisal of the evidence which is available. And also, even if that skill is available, time is not there to do this, because of the Dr. Jitesh was mentioning about the workload and all that. So hardly we find that there is a time for that. Now, second part of the question, how do you integrate this evidence-based resources into practice? I think one of the big drivers of evidence-based practice or the clinical guidelines used in India has been the accreditation. NABH was started, and one of the one of the standards they have is on whether standard treatment guidelines or clinical guidelines are followed for the treatment or not. Now NCOAS for the public hospitals. So these, in my opinion, these two are the major drivers of implementation or integration of this evidence-based practice into clinical practice. Secondly is, at an institutional level, this is at the systems level or the policies level. At the institutional level, I find when you use this as a yardstick, if you remember my last slide, I said evidence-based medicine in the environmental or the organizational context, So here comes the role of the organization, and if the organization use this as a yardstick, for example, all of you who are into this NQAS or NABH, you must be doing prescription audits. So you take up some key priority conditions where you think there is a lot of variation between the current practice and what is needed as per the evidence. And if you take those and then start measuring whether the prescriptions are adhering to this standard or not, that's one way of integrating. Second is, many a times people are not able to follow these evidence-based guidelines. As you also said, Dr. Dept said, best available evidence. So I would say best available medicine. Many a times when the medicines are not, aligned or matched with the what is mentioned in the evidence-based resource or a guideline, then also people go outside of these guidelines and prescribe medicine. So if you match your supply with the evidence-based, guidelines or the treatment plans, make those services available. It helps in you in integrating this into the your practice.
Yes, ma'am. Thank you. And there is another question. Maybe both you and Dr. Oommen both can share your thoughts. So again, with respect to the present condition, how COVID has changed the way the GP functions in India, and what role does clinical decision support play in embracing or hastening that change? And maybe both from a technological point of view and also from a grassroots or a realistic point of view. So both of you can share.
Yeah, thank you, Dr. Dept. So one of the things that happened during the surging phases of COVID is that large number of the traditional hospital-based healthcare providers shut their shops, and this is when people had to go to the nearest available person, and that was in-person visits were not possible. So basically, what you saw is that many of the GPs just put out their number on their in their groups to their patients as well as outside their clinics, and then a consultation moved telephonically, and then this whole concept of going back to the local doctor because somebody is nearby who can be available has really re-emerged, and we saw that happen both in rural areas as well as in urban areas. So that is one thing. Secondly, a lot of consults have now moved online or onto the tele platform. So here, when the consult is actually happening on a tele platform, if we are able to embed a clinical decision support as a plugin, then having the signs, symptoms, diagnostics alongside the decision support makes it a seamless experience both for the clinician as well as for the patient seeking care. So we are at a right moment for this switch, and I think 5-MCC is very, very well positioned to address this huge area of need. Over.
I think this is just to take this Dr. Oommen's point further. During this COVID pandemic, we found that every day there was new research coming up, new research paper coming up. Hydroxychloroquine, then initially lopinavir, like that. Many treatment, because we were fiercely looking for some solution treatment. Every day there was a new report coming. And social media was the one, was circulating all this information. So the general physician didn't know, whether to go by this research finding or not, because most of the time these were observational studies or record-based studies, or there was a small sample size. So, they couldn't make out what is the strength of the evidence in these reports. So in this kind of a setting, there is even a greater role of clinical decision support systems here, such as guidelines made by the government. Many people didn't know which remdesivir, at which stage do you need to give this, what is the role of plasmapheresis, tocilizumab. like that, and timing of these investigation, which investigation, and how do you interpret these investigations, this during this second wave, all the laboratories were overworked, and with the biomarkers, everybody was asking for it on day one, but people didn't know what to do with this. So I think clinical decision support for general practitioner is of greater relevance here in this kind of a setting here. And as being the one of the editors for the South Asian edition of 5MC, we contextualize this information and sorted out these evidence available, and these were updated in the 5MC accordingly.
Thank you, ma'am. Thank you for giving this feedback. Just one more couple of question for Dr. Jitesh. It has come up, so which is again, maybe participants want to relate with the scenario, I guess. Please mention any barriers or problems in diagnosing or managing the patient at the community level. So how do you overcome these challenges presently? So whether you seek knowledge through internet, or you just have a peer-to-peer discussion, something like that. So of course, that's the gap which we are trying to fill. Maybe you can just even articulate what are the challenges which you are facing currently, and how do you try to overcome it locally?
Dr. Dravid, actually, in right now, what we are doing is that we have our own communication between our peers, which is very strong. If we have any doubt regarding any diagnosis, we rely upon other person also, and we also use internet to search for the best available practices. But it's very difficult to judge whether to trust this available evidence. That is actually lacking. So
yeah, that's precisely the point.
We
How
are
much
in
you
a
can
sea
trust.
of we don't. That is fact issue what we are facing in a community level. So everyone is trying to be to provide the best available practice in our own limited resource scenario settings, but it is not always possible. As a person from public health, public institution, we don't have that much resources available to use, but we actually try our best to have updating our own colleagues through the informal groups and group discussions, and even clinical case presentations also. But that might not be possible in every scenario. So once in up to 20 to 30% of cases we can have this one, but 70 to 80% are not done like that.
Okay.
That is.
Thanks, Dr. Jitesh, and then I would like to thank once again all the speakers for giving their valuable time and sharing their knowledge and the resources, and also giving an overview of how clinical decision support would help the general physicians. And thank you so much. And also I thank the attendees and the participants who actively participated and asked questions. And as I said, there is a feedback form, so you can fill, and we would also reach out to you. And if you are interested in having a free trial of 5-minute consult, please feel free to fill the form, and then we would be happy to give access to 5-minute consult trial freely. And thanks once again. And we would share the recording of this webinar for everyone. Thanks once again. Thank you, ma'am. Thank you, sir. Thank you, Dr. Jitesh.
Thank you.